far as I remember, we could complete the 6A seminar. Oh. Yes, we could complete it, yes. So we are here now, and we should find time for some embryology today. So let's continue with the colon 53N, which is a longitudinal section with hematoxaniosin staining. So we are already in the large intestine, so we can compare the histological organization of the small and large intestine. Okay, so we can see the mucosa here from top down to here. This is the thickness of the mucosal membrane, which is a complete mucosa with all three sublayers present, just like in the small intestine. And then we have this connective tissue layer below, which is the submucosa. And then we have external muscle layer, like this. And then we have seemingly lots of white adipose tissue, and we will argue that this must be the subserosa, and the serosa is mainly lost. It is a simple squamous epithelium called mesothelium. That's the serosa. But let's look at the mucosa at higher power. The lining epithelium gives no surprise. The type of epithelium is the same as in the small intestine, simple columnar epithelium with goblet cells and striated border. One difference that here the density of goblet cells is higher than it was in the small intestine, generally speaking in the intestinal tract. As we are traveling more and more distally, the density of goblet cells will increase. And we have a relatively thick basement membrane here, the second thickest basement membrane of the human body. The first, the thickest, is the trachea. In the trachea, you know. On the other, yes?
How can I differentiate between the mucous cells and the goblet cells?
Between goblet cell and
Mucous cells.
mucous cell. The goblet cell is also a mucous cell. Here, the only mucin-producing cell is the goblet cell in this epithelium. I think you are confusing it with the lining epithelium of the stomach, where all cells are mucin-producing cells and there is no goblet cell. Okay, here you can see these columnar cells, which are absorptive cells called enterocytes. Such cells are not present in the lining epithelium of the stomach. Okay. So on the other side of the basement membrane, we have the laminopropria layer, and it is lymphoreticular connective tissue, just like in the small intestine. So lots of reticular fibers and lots of lymphoid cells are found inside. And one interesting point that in the laminopropria of the colon, basically there is no lymphatic vessel, only blood vessels are present, and this fact has a clinical relevance, because if a malignant cell is born in the lining epithelium, if it is tending to penetrate the basement membrane, first of all it takes time because this is relatively thick, this basement membrane, and second, even if it breaks the basement membrane and enters the lamina propria, because there is no lymphatic vessel there, the chance to travel to other organs is limited. Okay, so the spread of the cancer is relatively slow.
There is no lacteals.
No lacteal here.
But is there like a lymphatic drainage or nothing at all?
Literature says that in the lamina propria of the colon, practically no lymphatic capillaries are present. There are lymphatic vessels in the submucosa. Okay, so another thing that we have glands here, crypts of Lieberkühn or intestinal glands like this or like that, similar to those in the small intestine. The cell types in these crypts are also very much the same. One major difference, that in the crypts of the colon, there is no Punnett cell. More precisely, in adult humans, there is no Punnett cell in the crypt of the colon. In childhood, there are Punnett cells, but not in the adulthood. Otherwise, the other 5 cell types are also present here, just like in the small intestine, and we already discussed the cell types there, yes? Okay. Now, if we compare the mucosa of the colon and that of the small intestine, we can point to another difference, namely, here in the colon, there is no intestinal villus and there is no fold of Kerkring. So the only structure which increases the surface area for absorption is the microvillus on top of the enterocytes. Okay, that's a difference. One major function of this piece of the intestinal tract is to absorb water. So it involves material transport. That's why microvilli are present to facilitate this material transport. Nutrient absorption is practically absent here. And another thing, we mentioned that in human adults there is no Punnett cell at the base of the crypt in the colon. And you know, Punnett cells create antibacterial substances like lysozyme and alpha-defensin, which kill bacteria by disrupting the wall of those bacteria. Because these Punnett cells are missing here, or partly because of this fact at least, the lumen of the colon is not sterile, so it is full of bacteria which live with us in symbiosis. And this is in contrast with the lumen of the small intestine, where the bacteria are almost absent. And these bacteria here are useful, for example, because we humans don't have enzyme to cleave certain substances, but these bacteria have those enzymes, and for example, enzyme to break cellulose, which couldn't be digested otherwise, because we humans don't create enzymes to cleave cellulose. Okay, so the third layer of the mucosa is the muscularis mucosae. You can see here some smooth muscle cells are in cross-sectional view, some in longitudinal view within the muscularis mucosae. Below, we have the submucosa. So, I would say here, at least it is a dense irregular connective tissue. Some other descriptions say this is loose connective tissue. Well, the difference is not clear cut, and it is also dependent on the location where you look at it. And in the submucosa, we have submucosa plexus. Like here you can see one piece of the submucosa plexus. And for example, this one here is a ganglion cell with basophilic cytoplasm, euchromatic nucleus with nucleolus inside. This dark spot is the nucleolus. This is another ganglion cell body. Of course, there are blood vessels, also lymphatic vessels, like here. This is a lymphatic vessel. Lots of collagen fiber, capillary. Okay. Yeah.
Is the plexus, the submucosal plexus, the myenteric plexus, or is it?
No, myenteric plexus is here,
Oh, okay.
between the inner circular and outer longitudinal sublayer. Another thing, we have a secondary lymphatic nodule here with a pale stained germinal center. And here we have another lymphatic nodule, at least partially within the section. This is probably primary. There is no pale germinal center in the middle. These structures belong to the gut-associated lymphatic tissue, okay, which is part of the mucosa-associated lymphatic tissue. You know, we mentioned that another major subdivision of this mold is the bald bronchus-associated lymphatic tissue. So, diffuse lymphatic tissue associated with the mucosa of the respiratory tract. So that's the submucosa. And we have the muscularis externa, or external muscle layer, which is divided into an inner circular sublayer here, where smooth muscle cells are in cross-section. And an outer longitudinal sublayer here, where smooth muscle cells are in longitudinal view. Here, these structures are just folds, so artifacts created during sectioning. Between the two sublayers, we have the myenteric plexus, which looks exactly the same as the submucosa plexus, so we can distinguish it just on the basis of location. So, if you compare the external muscle layer of the small intestine and that of the colon, we need to point to a major difference, which is the continuity of the outer longitudinal sublayer. This outer longitudinal sublayer is present here in this section. But we know, and you also know hopefully from gross anatomy already, that along the colon, over the outer surface, there are three ribbon-like structures called taniae, which are absent in the small intestine. Histologically speaking, these taniae are nothing else than strengthening of this outer longitudinal sublayer of the external muscle layer. Meaning that since we have a well-defined outer longitudinal sublayer, we need to say that the plane of sectioning went through one of the three taniae. We cannot tell through which, but through one of them. If we couldn't see this outer longitudinal sublayer, or at least it would be very much underdeveloped, not like here, then we should say that the plane of sectioning didn't go through any of the tailiae. Okay? So, in certain planes of sectioning, this outer longular sublayer is present. In certain others, it is practically absent. But this phenomenon is true only for the colon, not true for the small intestine. Okay? Yes? Shoot, because I cannot hear. Oh. We have this noise here, and also you are far away. So. Right here, we can see the at least it will be very So, let's talk about the outermost sublayer. You know that there are parts of the colon which are retroperitoneal, the ascending and descending colon, and the transverse and sigmoid colon are intraperitoneal. Well, histologically speaking, if an organ is intraperitoneal, the outermost tissue layer is subserosa and serosa. If it is not intraperitoneal, it is adventitial. Now the problem here, as you know, that mesothelial cells which create the serosa are usually lost. So if we cannot see them, it may be because it was there but we lost it, but it may also be the reason that it was not there at all. So how can we decide? Well, we can decide because we can see this quite large amount of white adipose tissue here, which is characteristic for the subserosa of the colon. So because of the presence of this, we can say that this is subserosa, and the serosa is mostly lost. And it also means that this sample was taken from an intraperitoneal part of the colon, so it may be from the transverse colon, but may also be from the sigmoid colon. We cannot tell because histologically they are identical. Okay, is this something what you could follow?
So to the right it's adventitial?
No, because here you can also see
No,
this.
in the middle, between them. So it's...
No, it is not adventitia. This is subserosa. Well, here it is thinner, if you mean that. Also, it is thinner here.
But in between them, there is nothing.
Here.
Yeah, exactly.
Yeah, here. But you know, it is not possible that we have such a small retroperitoneal territory, and then on both sides we have intraperitoneal territory. So we must assume that this is just a territory where adipose tissue was lost during sectioning, but it was also there.
Looks like there's an artifact above it as well, right?
This is, yes. So this is artifact, yeah. So that's the logic. All right, so that's the column. Can we go on? So, appendix vermiformis number 52. So this is cross-section, which is a major difference. This is an extension of the cecum. And there is no tania here along the vermiform appendix. And we can prove this. But first of all, let's look at this something which is incomplete structure seemingly. This is where the duplicated peritoneum, so the mesentery, reaches the organ, okay, and surrounds it. This is an intraperitoneal organ. And this territory where the mesentery reaches the organ, this is the mesoappendix. This territory is the mesoappendix. Now, let's look at the lumen and the mucosa. The lining epithelium is simple columnar epithelium with goblet cells, and some striated border is visible. Goblet cells here have a rather basophilic cytoplasm, which may be due to two different reasons. We cannot tell which is the most reasonable explanation. I don't know which statement. So I just mentioned that this is simple columnar epithelium with goblet cells and striated border, and the cytoplasm of goblet cells is rather basophilic here. And it may have two different reasons. One, here not formalin was used as a fixative, so mucin was preserved, and mucin is a basophilically stainable substance. So this is one possible explanation. Another possible explanation that although here maybe formalin was used as a fixative, but because of the chemical nature of this mucin is different, therefore it may be preserved a little bit, preserved enough to be stainable by hematoxylin. Because you know the type of mucin which is produced in different parts of the alimentary canal is different. Anyway, we have lymphoreticular lamina propria, and we can see muscularis mucosae, smooth muscle. So we could say that this is a complete mucosa, but look here, the muscularis mucosae ends also here. But if we go on, here muscularis mucosae reappears, then disappears. And this is because here we have a very large lymphatic follicle which disrupted the continuity of this muscularis mucosae. So originally it was continuous, but these lymphatic nodules are born in the lamina propria by accumulation of cells. But they grow so big that they cannot be fitted in the lamina propria and disrupt the muscularis mucosae, and that's why they shifted to the submucosa. Actually here, most part of the nodule is within the submucosa already.
If you look at the circle, it like forms a little circle that darkens around.
Okay, so this is the lymphatic nodule, this whole thing. And inside this paler circular territory is the germinal center, and around this darker territory is called the mantle zone. Mantle zone. Mantle zone.
There's
This
several.
darker cap, mantle zone.
Is there a function to it? Is there some reason or something?
Yeah, we will learn it later. As I think I have mentioned that one major function of the lymphatic nodule that B lymphocytes are differentiating here. Some of them die. Some others differentiate into either plasma cell or into B memory cell. The details of the process is coming later. So, all in all, we have a discontinuous muscularizing pose. And this is a territory where these lymphatic nodules are grouping. So lots of them are together. In the previous section, remember, we could see only 2 lymphatic nodules. So they are not grouping. You cannot say that. Those lonely lymphatic nodules may be called as solitary lymphatic nodules. Here they are grouping, and there is another very characteristic territory in the alimentary canal where lymphatic nodules tend to form groups. That's in the ileum. We don't have section from that territory. And these aggregated lymphatic nodules, which are in the ileum typically, have an author's name. Do you know that name? Peyer's patches, yes, with capital P and the Y inside, Peyer's patches. Okay, so we have submucosa. This is just an artifact, some dirt. It is not a spider or something. And also these radially oriented reddish line-like structures are artifacts. These are just tissue folds. Also here. But outer part, from here to there, this is the external muscle layer, outer to the submucosa. And the organization is that we have an inner circular sublayer, like this, and an outer longitudinal sublayer. Okay. So the organization of the external muscle layer is the same as in the small intestine. The only difference, the plane of sectioning, okay, so that's why the outer longitudinal sublayer is seen in cross-section, while the inner circular is seen in longitudinal view. And this is different if you change the plane of sectioning to be longitudinal rather than cross-sectional like here. But in reality, the orientation is the same, just in different viewing angles, how we look at that. But what is more, or at least as important, if you look at the thickness of this outer longitudinal sublayer along the perimeter, it is about the same everywhere, okay? Which means there is no tenure here, because otherwise the thickness would be variable. We could see, or should see, 3 thickened parts and very underdeveloped parts in between, if they were here, but they are not present in this territory, no tania. That's why we can say that this outer longitudinal sublayer is continuous, meaning that the thickness is equal everywhere. Yes?
If you look between the muscles, the longitudinal or like the circular sectioning in the lymphocytes. There's like more collagen.
Sorry, I couldn't follow. Circular sectioning of
the
lymphocytes.
No, between the circular sectioning of the smooth muscle in the external muscularis.
Here,
No,
myotic plexus.
No, the one more deeper to it.
Here,
No, deeper, like closer to the center.
this.
No, so between this section, like where you are now, and between the lymphocytes, there's like a higher collagen-rich layer.
This is the submucosa.
It's part of the submucosa.
Yeah, lots of collagen. That's why it is eosinophilic. The muscle is always paler. We already discussed that. So the outermost tissue layer is subserosa and serosa, but we again lost the serosa layer at least many places. But look here, some mesothelial cells still present. Okay, but not everywhere. Here there are some. Here also. But here they are just missing. But obviously it is a continuous row of cells in reality, creating the serosa. So that's it. Can we continue? So if you don't mind, I wouldn't show the other appendix vermiformis because basically no difference. So let's continue with the rectum, 55. Again, a longitudinal section. Actually, it is called rectum, but in reality it is the anal canal only, which is part of the rectum, anal canal. And in this orientation, here is the lumen, of course, content of which was lost. And to the right we have the proximal part of this anal canal, to the left we have the distal part. And along the length we can differentiate three zones which are which have distinct lining epithelia. So the first zone is this territory called columnar zone. You may read somewhere else colorectal zone, that's the same. And here, if you look at the lining epithelium, it is simple columnar epithelium with goblet cells and striated borders, so exactly the same as in the colon or on the small intestine. So the columnar nature of this lining epithelium may describe the name columnar zone, but there may be another explanation for the name, because in cross section this territory looks like this. So this is the lumen, and the blue line is the wall of the columnar zone. And the point is that we have these structures like this, or like this, or like this, which form longitudinal columns. They are called anal columns. Okay? So that may serve as another explanation for the name columnar zones, the territory where we have these anal columns. Okay? And below here, these may be
term these territories as sinuses, and these sinuses have a simple columnar epithelium. Here on top of these mucosal folds, we have stratified squamous non-keratinizing epithelium. So one possible explanation, what we can see here, is that this is the columnar zone, and the plane of sectioning goes through one of the sinus. So, like here, for example, or like here, so where we are at the bottom. Because if it was go through here on top, we could see simple squamous non-keratinizing epithelium and not simple columnar. Which makes sense because the faces is traveling here, and in these evaginations the friction is higher, so it has to have a more resistant type of epithelium, like stratified squamous non-keratinizing, which is more resistant than the simple columnar. If it makes sense for you. And also, I can show you a drawing, I think.
Can you show us on the slide where the crossing between the non-keratinized epithelium and the columnar?
No, but I can show you a drawing. So this drawing is from Hungarian books. So actually, I have two drawings from two Hungarian books, but it doesn't really matter. So this is a longitudinal view, and you can see the names of zones. The first zone is the zona columnaris, or columnar zone, okay? In Hungarian we call it zona columnaris. And these green structures are the anal columns, what I try to draw in cross-section. Here you can see them in longitudinal section, okay? Now at the base of these columns, where the next zone starts, which may be called as intermediate zone or zona intermedia, but you may hear transitional zone, another name, but my favorite is a third one, hemorrhoidal zone. Hemorrhoidal zone. Hemorrhoidal zone, and I tell you why it is my favorite. And it is also written in the handbook, and not handbook, handout. So first of all, please observe this abrupt transition from simple columnar epithelium to stratified squamous non-keratinizing epithelium. This is characteristic for the next zone, which is the hemorrhoidal zone. The name comes from the Greek word hemorrhoid, which means blood flow. Hemorrhoid means blood flow. And why? Because look at here, underneath the epithelium in this lamina propria, we have lots of veins. These structures are all veins. So blood is flowing, of course, in these relatively big veins. So maybe that's the origin of the name hemorrhoidal zone. And because these veins have clinical relevance and also pharmacological relevance, I prefer this name, hemorrhoidal zone, what you can also read in the handout written by the department. We will return to this point, but let's go on and look at another transition where keratin layer starts to appear, this eosinophilic territory, and from the surface, nuclei disappear, meaning that this is already a stratified squamous keratinizing epithelium. And we arrive at the third zone, which is called cutaneous zone. Cutaneous zone. You know, the name comes from the Latin term cutis, which means skin. And really, this is here already skin, composed of epidermis and underlying dermis. The connective tissue layer here is called dermis. This is formed by invagination of the proctoderm during embryological development. Cavity is formed, kind of invagination around the cloacal membrane. So, because of this, it is obvious that this territory is continuous with the skin. So, that's why this is already skin. So, we have three zones characterized by different lining epithelia. But let's come back to the columnar zone. Here, the lamina propria is still lymphoreticular connective tissue. And underneath we have a muscularis mucosae here. Then we have submucosa, of course. And then we have external muscle layer, composed of inner circular, outer longitudinal sublayer, no tenia already, and this is no longer intraperitoneal, so the outermost tissue layer is adventitia.
But there's still adipose tissue, no?
Hmm?
There is still adipose tissue.
Yeah, that's true. What I said, it is for the colon and not for the rectum. Okay, so let's go back here to the muscularis mucosae. And we try to follow this muscularis mucosae. And in the meantime, look at the transition. We are leaving the columnar zone. And when we are leaving it, this muscularis mucosae becomes disrupted. It's no longer a continuous layer, and then tends to disappear completely. So in the hemorrhoidal zone, after a while, the muscularis mucosae disappears, which means we cannot talk about separately submucosa, because the submucosa and the lamina propria is something which is separated by the muscularis mucosae. Which means in the hemorrhoidal zone we have an unified connective tissue-like tissue. We call it fibromuscular connective tissue because smooth muscle cells intermingle with connective tissue. So the point is, because muscularis mucosae cannot be identified anymore, therefore we cannot talk about submucosa. We have a unified lamina propria and no submucosa. And in this territory, you can see this inner circular sublayer of the external muscle layer is thickening and forms a sphincter muscle called internal anal sphincter. Internal anal sphincter muscle, or inner anal sphincter muscle, which is controlled by the autonomic nervous system, so independent of volition. Here at the outer part, we have some striated muscle fibers in cross-sectional view. This is not part of the wall of the anal canal. It is here from the perineum. It is called levator muscle, but it is not part of the wall of the anal canal anyway. So this is the point where we should talk about these relatively large veins here in the lamina propria of the hemorrhoidal zone. This is the territory where the portal and systemic circulation anastomose. So connections are present between the two systems of circulations. And it means that if, for example, blood flow gets obstructed within the portal circulation for whatever reason, for example, because blood flow gets obstructed in the liver because the liver has liver cirrhosis, lots of connective tissue fibers, which is pathological, blocking blood flow through the liver, then obviously blood needs to flow in other directions, which is possible because of the anastomosis, and it will result in an increased blood pressure in these veins, and it will result in dilation of these veins. And if these veins get dilated, then you can imagine that they may bulge the lining epithelium towards the lumen, forming so-called external hemorrhoids. Feces is traveling here along this surface. And if we have a bulging territory, an external hemorrhoid, then obviously it creates an obstruction, increases friction, and the epithelium may start to erode. And once it gets eroded completely, the underlying small wall of the vein may get eroded as well, and bleeding starts. Of course, all this is painful for the patient. So this is one clinical significance. The pharmacological significance is that if you give medicine through the anus, and it absorbs through this epithelium into this venous plexus, then this pharmacon, the medication, can be more effective compared to the case when the same medication is administered through the oral cavity. And the reason is that if this substance is absorbed into this venous plexus, to the blood, then because of the anastomosis exists between the systemic and portal circulation, part of this blood may avoid the liver, at least for a while, where liver could destruct the pharmacon. As a result, this medication remains in blood circulation for a longer period of time. So that's the pharmacological significance. Yes.
What if you, there's non-keratinized under the tongue as well, right? There's non-keratinized.
That's another location which is used in angina pectoris. Then medication, nitroglycerin, is put underneath the tongue, and that can absorb very well there as well.
That bypasses the liver completely, no?
Hmm?
This bypasses the liver completely.
No, not completely,
No?
because part of the blood is flowing through the liver, but because for blood flow there is another direction, direct to the systemic circulation, then part of the blood will avoid liver, not forever, but at least not directly flowing through the liver. Okay.
Which stage the muscularis mucosa is disrupted?
The muscularis mucosae gets disrupted as we leave the columnar zone and enter the hemorrhoidal zone. Okay, so let's look at, yeah. connective tissue part is called lamina propria and no submucosa. Yeah, the name of the tissue type of the lamina propria is fibromuscular connective tissue. And this organization, that connective tissue and smooth muscle is intermingling, is typical here, but not only here. For example, in the wall of the vagina, this is also typical. And also in the so-called corpora cavernosa of the penis, this kind of tissue intermingling is also typical. Plus the presence of large dilated vessels are also typical in these other organs. So if we leave the hemorrhoidal zone, enter the cutaneous zone, where stratified squamous keratinizing epithelium appears, we can say that this is already epidermis, okay, and not epithelium mucosae, because this is no longer mucosa, but skin. And the underlying connective tissue as a tissue layer is called dermis and not lamina propria. Again, because we are already in skin. That's another thing, that the epidermis is continuous with the epithelium mucosae and the dermis is continuous with the lamina propria. In the skin region, the cutaneous zone, we have glands, like sweat glands, not very typical, but these are sweat glands here. And there are also sebaceous glands like this, or this.
These are apocrine glands.
There are also apocrine glands. I probably cannot show it in this section, but there are. Especially around the anus, called circumanal glands, which produce special chemicals, pharmacons, which act as chemoattractants. You have probably seen small cats playing and smelling each other's anus. That's because they try to make sure that they are playing with another cat which belongs to the opposite sex, because the smell is different. We humans have more refined methods to find out the opposite sex. Yes? This? It's a good question. Maybe it is just a dilated portion of a hair follicle associated with the sebaceous gland. Hmm? This one? Probably yes. Yeah. What is more important, however, that here you can see these striated muscle fibers in cross section, which form the so-called external anal sphincter muscle. External anal sphincter muscle, which is controlled by obish, not by the autonomic nervous system. And so we have two sphincter muscles here. The internal anal sphincter, which is under the control of the autonomic nervous system. If it fails, we are still preserve faces, because we can control the external anal sphincter. If this muscle also fails, then we are in a big trouble unless we have a toilet nearby.
Can you show the innervation?
Probably not, because obviously it is innervated, but nerve fiber. Well, can you see this?
Oh,
The tiny nerve fiber.
so is this also the myenteric? Or is it already?
In this territory, it is no longer called myenteric plexus because it is no longer smooth muscle here. And it is in the columnar zone. Visible or not, that's a different story. Well, it's visible. Can you see? It's paler territory. Between the inner circular and outer longitudinal sublayer. So the outermost tissue layer is everywhere adventitia, okay? And one point which is already related to embryology. Here, at the border of columnar zone and hemorrhoidal zone, I show you the location in this drawing. This is here at the bottom of these anal columns, this territory where columnar zone and hemorrhoidal zone meets. And embryologically, it is important because the lining epithelium of the columnar zone and hemorrhoidal zone are from different germ layers. The lining epithelium of the columnar zone is from the endoderm, like the lining epithelium of the primitive gut. But the lining epithelium of the hemorrhoidal zone and cutaneous zone is from the ectoderm, because it is formed from the proctoderm. And the clinical significance of all this is that wherever we have a territory in the body where derivatives of different germ layers meet, like here, then we don't understand why, but the frequency of cancer is higher in these territories. There is a similar territory, we will learn, in the vagina, because the upper part of the vagina is from the mesonephric duct, which is mesodermal, and the lower part of the vagina is from the cloaca, which is endodermal. And this line-like border has a name. It is called pectinate line. And I think now I should open the embryology presentation. If I can find it. So this is the slide I am looking for. So pectinate line is the border, which is just below the columnae, anal columns, which separates the lining epithelium, which has endodermal origin, and the other part which has ectodermal origin. And yeah. But so we already talked about the development of the respiratory tract. Okay. So I missed that part. Instead, I would start here, I think. Well, maybe I already projected this, but you know, during the lateral and craniocaudal folding. The rostrocaudal axis of the embryo is increasing. As a consequence, it is bending. And also at the same time, the lateral body wall is converging in the midline and eventually will fuse, except where the vital duct is present between the midgut and the yolk sac. That's the territory of the future umbilicus, and this will give rise to the future umbilical cord. So we have craniocaudal folding and lateral folding, and in relation to this, the primitive gut is formed, okay? Which is communicating with the yolk sac. Now, and this primitive gut can be divided into 4 parts, which are listed here. So what are the borders? The pharyngeal gut is separated from the foregut, where this respiratory diverticulum appears. So pharyngeal gut is from the buccopharyngeal membrane to this respiratory diverticulum, which gives rise to the respiratory system. Here the foregut starts, and it will end where the liver bud appears, which is an outgrowth of the primitive gut at the border of the foregut and midgut. We consider that the liver bud is still belong to the foregut, so liver is from the foregut. So beyond that, midgut starts, and it will end where the proximal 2/3 of the transfer colon ends. That's the distal border of the midgut, and beyond that we have the hindgut, which extends as long as the pectinate line. Okay, that's the end of the hindgut. And because of this, you can see the derivatives of the foregut, midgut, and hindgut. Derivatives of the pharyngeal gut is not listed here. That's a very much different story. We don't deal with that now. The endoderm gives rise to the lining epithelium of the gut and also the parenchyma of the liver and pancreas. And the slumping mesoderm around the primitive gut is the origin of the muscle part of the wall of the primitive gut, and also the peritoneum which surrounds the gut. And this is a side view showing the dorsal and ventral mesenteries. So this kind of color is the mesentery, and this dorsal mesentery extends, which is written here, from the lower end of the esophagus as long as the cloaca. But the ventral mesentery only visible from the caudal part of the esophagus as far as the bile duct appears. Actually, the liver, which is an outgrowth, grows into the septum transversum. This brown something is the liver, and where the liver appears here, it divides this ventral mesentery into 2 parts. One, which is in front of the liver, called falciform ligament, and the other one which is behind the liver and in front of the caudal part of the esophagus, in front of the stomach and in front of the proximal part of the duodenum. This is called lesser omentum, or lesser omentum. And this dorsal mesentery is also divided into several parts, reflecting the territory which are interconnected. So all parts will connect different organs to the posterior body wall. So parts of this dorsal mesentery are in these blue rectangular boxes. And names of arteries which supply the foregut, midgut, and hindgut are underlined in red. So these are three major arteries: celiac artery, superior mesenteric artery, and inferior mesenteric artery. So if you know this, and you know this, which part of the primitive gut gives rise to which part of the alimentary canal, you already know which artery supplies the organs of the alimentary system. So we already talked about the development of the respiratory tract, so I skipped that. Yeah. Let's continue with the formation of the stomach, which involves rotation by 90 degrees along two different axes. These are from your official embryology book, by the way. I just put here several notes, but the drawings are from your official book. So the stomach is rotating along its rostrocaudal axis and also along an anteroposterior axis. And rotation along the longitudinal axis means that the two vagal nerves, the left and right vagal nerves, change their position, and the left one becomes anterior in position and the right one becomes posterior in position. But another consequence of the rotation of the stomach is that ligaments change their position. Also, the liver will assume a right-sided position, and the ligament which connects the stomach and the liver will shift it to the right, and the one which connects the stomach and the developing spleen shifts to the left. This is the gastroligandal ligament. And a further consequence of these rotations is that here, behind the stomach, a part of the abdominal cavity is formed called omental bursa. Omental bursa. Okay, so these are consequences of the rotation of the stomach. So side view again. So omental bursa, this cavity behind the stomach, but also between the four layers of peritoneum which are here, forming the greater omentum, which extends downwardly from the stomach and will cover the small intestinal loops and also the transverse colon. And later, these four layers fuse. Actually, the inner two layers fuse, like here. So the cavity disappears here. Also, this cavity will disappear because this ligament and this ligament will fuse also. So here the omental bursa becomes smaller. You can see the retroperitoneal position of the pancreas and duodenum. And yeah,
That ligament that combines together before the colon, it's the gastrocolic.
yes, yes, it is not written here, but yes. So the opening of the omental bursa is called epiploic foramen. Epiploic foramen. You probably put your finger into this hole in the dissection room. It is important to know from what directions a surgeon can reach the pancreas if pancreas needs operation. So these three arrows show the possible routes how pancreas can be reached surgically through the lesser omentum, through the ligamentum gastrocolicum, and through the mesocolon transversum. And here is this epiploic foramen, what we are talking about. And this is a transverse view showing the rotation of the duodenum together with the pancreas. So originally both organs are intraperitoneal, entirely surrounded by peritoneum. But then there is this clockwise rotation and degeneration of part of the peritoneum here. And the result is that these two organs become retroperitoneal, meaning that only the anterior part of these organs are covered by peritoneum, and the other part is fixed to the posterior body wall. And such organs, which originally intraperitoneal but later becomes retroperitoneal, these are called secondarily retroperitoneal organs. Secondary retroperitoneal organs. So the pancreas and the duodenum, well, except the very proximal part of the duodenum, these are secondarily retroperitoneal organs. And another story, that during development of the midgut, it grows very fast, starting from week 6. So fast it is growing that it cannot be fitted into the abdominal cavity of the embryo. As a consequence, it herniates into the herniates through the umbilicus, and this herniation is called physiological umbilical hernia. Physiological because this is normal to happen at this age, but between week 10 and 12, normally this intestinal loop returns to the abdominal cavity. Sometimes this fails, but while it is herniated, it rotates along the superior mesenteric artery, first by 90 degrees, then by further 180 degrees. And this rotation establishes normally the normal left and right sideness of different parts of the alimentary canal. This rotation may also fail, sometimes even rotates inversely, resulting in the reversal of the sightness of the different parts of the alimentary canal. And it also can happen that this hernia doesn't disappear. And this is called omphalocare, when this hernia doesn't retract. And the protruded parts of the primitive gut are covered by amnion.
It's in the umbilical cord right now. This is the proximal part.
Yes, that's the territory of the umbilical cord. Yes, here you can see it is here. But there is another way how certain parts of the alimentary canal may remain outside the body wall, which is not due to the fail of return of the herniated part of the midgut, but it is due to the failure of closure of the ventral body wall. In this case, these organs which remain outside the body wall are not covered by amnion, and the name of this abnormality is gastroschisis, not omphalocare. And well, another probable malformation is the imperforate anus, when anus just missing.
What about the rectum? Is it still inside?
The rectum may be still present, but the rectum has other abnormalities, fistulas, small connections between the rectum and the male urethra may persist. In the female, connection between the rectum and the vagina may persist. Okay, because the urethra and also this lower part of the vagina develop from the cloaca. And regarding malformation of the hindgut, one possibility is the Hirschsprung disease, which is nothing else than the development of autonomic ganglia, parasympathetic ganglia in the wall of certain part of the colon will not develop, or at least will not develop normally, may completely missing. These ganglion cells are from the neurocrest. So if they are not developing properly, then the peristaltic movement fails in this part, meaning that the food, the content of the colon cannot be transported through this territory, meaning that it remains in the more proximal territory, which therefore becomes dilated, forming a so-called megacolon. And the more distal part, where ganglia are missing, where transport is not really possible, it is thin because of the lack of content, basically. So this is the Hirschsprung disease. And what else? Well, yeah. This is, okay, let's talk about this. This is the last, I think, what we can talk about. The Meckel's diverticulum, which is the remnant of the vitellointestinal duct, which interconnects the midgut, the future ileum, with the yolk sac through the umbilicus. Normally, this extension disappears, but sometimes it remains, and it is called Meckel's diverticulum in this case. This is an author's name, capital M. And it may connect to the umbilicus via the Vitellin ligament. Sometimes even a cyst is formed, and some other times a narrow connection will persist between the ileum and the umbilicus, which also means that faces may appear in the umbilical region if this abnormality is present. This is a further one, which is due to abnormal development or atresia of blood vessels, which may result in apple pea atresia, which means this spiral arrangement of the intestine. This is due to problem with blood supply. Yes.
The Vitellin duct turns into the urinary bladder. Is that the one? Or
No. The urinary bladder is from the cloaca.
then what happens to the Vitellin duct after a certain development?
It normally disappears.
Disappears completely?
But this is the point. When it doesn't disappear, these abnormalities may persist. But normally it disappears. Yeah. So I think time is over, but we could highlight at least some major points around which you can develop your knowledge. So thank you very much. We will meet next time this week. Please turn the computers off.